Okay.
I think there's a bit of an echo. Can everybody turn off their mics?
Can you share, give me privileges for cath lab reading room?
Sure. Right, I can see your slide.
Can everyone see my screen?
Yes.
I can. It's not full screen. It's sort of in the working view.
Oh, you know why? No, so here's what you should do. Unshare. Stop share. So now share screen. Okay, and share the screen.
This one.
Yeah. And then now go into the screen there.
Is that better?
Yes, it's full screen now.
Yeah, perfect. Thank you, everyone. My name is Zane. I'll be presenting Master DAPT trial. It was published in October 2021 in New England Journal of Medicine. The article is titled Dual Antiplatelet Therapy After PCI in Patients at High Bleeding Risk. So I'll go through just the background, methodology, results, and the conclusion of the manuscript. Just to start off with the background, as we know, antiplatelet therapy is the mainstay treatment of choice in patients following PCI with stents. And it's really in order to maintain this balance here between the risk of bleeding and stent thrombosis and leading to ischemic risk. There are many patient, clinical, and procedural factors that can increase risk of ischemia and stent thrombosis. That includes advanced age, ACS, multiple prior MIs, extensive CAD, diabetes, CKD. And then there's also procedural characteristics as well that can increase risk for stent thrombosis. First generation drug-eluting stents, stent undersizing, underdeployment, bifurcation stents, and in-stent restenosis all increase risk for stent thrombosis. In terms of bleeding risk, there's different patient characteristics that have been shown in multiple studies to increase bleeding risk. And that includes a history of prior bleeding, if they're on anticoagulation, female sex, advanced age, CKD, anemia, and if they're on chronic steroids or NSAID therapy. The 2016 ACC and AHA guidelines on dual antiplatelet therapy give a class 1 recommendation for patients who have stable ischemic heart disease. You want to continue DAPT for at least 6 months. In patients with ACS, including NSTEMI or STEMI, you want to continue DAPT for at least 12 months. They do mention patients who are at higher risk of bleeding. So patients with stable ischemic heart disease, it's a class 2B recommendation to that it's okay to discontinue P2Y12 inhibitor therapy after 3 months. And patients who have had ACS, it is reasonable to discontinue PTY12 inhibitor therapy after 6 months in patients who are at high risk for bleeding. They did update this recently in 2021. They did make a subtle but important update in terms of discontinuation of antiplatelet therapy. So as you can see here in this diagram, you have following PCI in patients who have stable ischemic heart disease versus ACS. There is a class 2A recommendation for both about potentially discontinuing. They mentioned aspirin and continuing P2Y12 monotherapy after 1 to 3 months. So a lot of those studies that were used in these guidelines actually did not look at high-risk bleeding population specifically. A lot of those studies were limited to non-ACS patients as well. Thus, the duration of DAPT to prevent ischemic complications while limiting bleeding risk in patients who are high risk for bleeding remains unclear. So this study, the objective was to conduct a randomized control trial in patients who are at high risk for bleeding, who've had a PCI, specifically with this biodegradable polymer sirolimus-eluting stent, and to evaluate 1 month of DAPT versus the longer course of DAPT, and to assess clinical outcomes of both ischemic events and bleeding. So let's go straight into the methodology of the trial. So again, this trial is called Master DAPT trial. Stands for Management of High Bleeding Risk Patients, Post-Bioresorbable Polymer-Coated Stent, implementation with an abbreviated versus standard DAPT. So this was a multi-center randomized open-label non-inferiority trial that was conducted from February 2017 to December 2019 at 140 sites in 30 countries. The criteria for this trial included patients who had an acute or chronic coronary syndrome, who had undergone PCI for 1 or more lesions with this Terumo stent. It's called an Ultimaster stent. These patients should not have had further revascularization of additional lesions. And then in order to be deemed high bleeding risk, they needed at least 1 or more of the following criteria. So this is the criteria that they used. So we can just go through them really quickly. One of the criteria was a clinical indication of treatment with oral anticoagulation for at least 12 months. If they had a recent non-access site bleeding episode that required medical attention, if they had previous bleeding episodes that required hospitalization, age of 75 or older, if they had systemic conditions that increased bleeding risk, including hematological disorders, they have current thrombocytopenia, which they defined as a platelet count less than 100,000, or any other known coagulation disorder. They had documented anemia, which they defined as a hemoglobin of less than 11. If the patient was on chronic treatment for steroids or NSAIDs, if they had a diagnosed malignancy that would increase their bleeding risk, including GI, renal, and pulmonary, if they had a recent stroke in the past 6 months, or a TIA, and then if they had a precise DAPT score of 25 or more. And the precise DAPT score, it includes age, includes prior bleeding, hemoglobin, white blood cell count, and creatinine clearance. And the score ranges from 0 to 100, and patients who are greater than or equal to 25 are considered high risk for bleeding. So in this trial, what they did was they actually screened the patients prior to randomization. So these patients underwent PCI, and then they waited about 30 to 44 days after PCI to make sure the patient didn't have any ischemic complications within that first month post-PCI, to make sure they didn't have any active bleeding events, and to make sure that these patients were adhering to their dual antiplatelet therapy. Their reasoning for wanting to do this this way is because they wanted to screen they wanted to screen out background noise by not including events that were occurring in that first month when both arms were on the same DAPT treatment. So that was their reasoning. That does have some implications that we can talk about at the end. But once they met that criteria, so no ischemic complications, no bleeding events, and adherence to DAPT, they were then randomized in a 1-to-1 ratio to either abbreviated DAPT or standard DAPT. And we'll go into in the next slide of what that means. And then these patients had follow-up visits at the first month, so 60 days after randomization, 6 months post-PCI, and 1 year post-PCI. So these were the two treatment groups. It was abbreviated DAPT versus standard DAPT. And so what this signified was that, so both treatment arms started off with dual antiplatelet therapy, which they defined as aspirin plus a P2Y12 inhibitor. After that first month following PCI, the patients in the abbreviated DAPT went on a single antiplatelet therapy. And that could be either aspirin or a P2Y12 inhibitor. They left it up to the discretion of the physician. And then the patients who were in the standard DAPT group continued their DAPT, the dual antiplatelet therapy. There were patients who were on oral anticoagulation as well. And in these patients, so if they were in the abbreviated DAPT group, they extended their DAPT treatment. So they went from, so they included DAPT for 1 month, but and they extended the SAPT to 6 months. In patients who were in the standard DAPT treatment, there were two options. Patients continued their DAPT for 3 months and then went on a single antiplatelet therapy, or they just continued their DAPT to 12 months. Patients who went on a single antiplatelet therapy plus the oral anticoagulation, they mandated that the patient be on clopidogrel. And their reasoning for that was the only acceptable P2Y12 inhibitor that has been studied in combination with oral anticoagulation. So in this group, in patients who were on single antiplatelet therapy plus oral anticoagulation, they were specifically on clopidogrel. Their dosing that they chose was not standardized. There was some variety in terms of the dosing. They left it up to guidelines and local practice. So the aspirin dose did vary from 75 milligrams a day to up to 162. Clopidogrel was 75 milligrams once a day. And then prasugrel, you could have the standard dose of 10 milligrams a day, or the lower dose of 5 milligrams per day in patients who are at higher risk for bleeding. In Japan, they do have a different dose of prasugrel, and that was accepted in the trial. And then ticagrelor was prescribed at the standard dose of 180 milligrams per day, or 90 milligrams BID. There were 3 primary outcomes that the trial looked at. The first one was net adverse clinical events, which they defined as a composite of death from any cause, from MI, stroke, or major bleeding. The second primary outcome was major adverse cardiac or cerebral events, which was a composite of death from any cause, MI, or stroke. And then the third primary outcome was major or clinically relevant non-major bleeding, which could have occurred between randomization or the 335 days of follow-up. They also listed secondary outcomes as well that they looked at. So they looked at the individual components of each of those 3 primary outcomes that we just discussed. They looked at composite death from cardiovascular causes, MI, and stroke, death from cardiovascular and non-cardiovascular causes, stent thrombosis, and all bleeding events. And their analysis, so what they did was they calculated the cumulative incidence of each of those outcomes at the end of follow-up, so 335 days following randomization. And then they calculated the difference of the cumulative incidence of each of those outcomes between the abbreviated DAPT group minus the standard DAPT group. And then in terms of their analyses, for the first two outcomes, so for the net adverse clinical events and major adverse cardiac and cerebral events, they performed per protocol population analysis. So meaning that they actually excluded patients who did not meet selection criteria, even after randomization. But for that the third outcome that they're looking at, the bleeding outcome, they performed an intention to treat analysis. So once those patients were randomized, they were included in the analysis when they were looking at the outcomes for bleeding. So the results, so from February 2017 to December 2019, 5,204 patients underwent screening. Of those patients, 88% were randomly assigned to either the abbreviated DAPT group or the standard DAPT group. Median time from PCI to randomization was about a month in each group. So the first thing they looked at was randomization effective. As we know, randomization is to minimize any potential confounding between both measured and unmeasured variables and the outcome of interest. So looking at this, want to make sure that randomization was effective between the two groups. And as you can see, the overall characteristics of patients at baseline and their clinical presentation was approximately the same between the two groups. Median age of patients was about 76 years. 69% of the patients were men. 33% had diabetes. 19% had CKD. 19% also had heart failure. 10% had peripheral vascular disease. And as you can see here, about 36% of patients were on oral anticoagulation as well. In terms of clinical presentation, about 40% presented with stable angina, 25% presented with an NSTEMI, 12% presented with STEMI, and 11% presented with unstable angina. So we went through their definition of how they defined high risk for bleeding. So how high risk was this patient population? So as you can see here, so this is the abbreviated DAPT group, and on the right, you'll see the standard DAPT group. You can see that, first of all, between the two groups, again, randomization was effective. Both groups are similar in terms of how high risk they are. About 36% of the patients were on oral anticoagulation for greater than 12 months. Of those patients, about 11%, that was their only criteria for meeting this high risk bleeding definition. About 69% were deemed high risk because of their age. Of those 17%, this was their only criteria that they met for being high risk. And then about 55% met this definition of high risk bleeding because of their precise DAPT score being high. Here are procedural characteristics of the PCI between the two groups. Again, randomization was effective for both groups. The characteristics are pretty similar, but 84% of the patients, the arterial access site was radial. 75% had just one vessel treated. The LAD was the most common vessel that was treated, followed by the RCA. 21% had 2 lesions treated. Again, 21% had 2 stented lesions. 68% of the patients had at least 1 complex lesion. And then looking at the characteristics of treated lesions, again, similar for both groups. 16% had a bifurcation or trifurcation lesion. And down here below, this was a little surprising just from my own personal experience. About 30% had a direct stent. So the lesion was not pre-dilated. And then 62% were post-dilated. So about 40% did not have post-dilation of their stent. There was no mention of imaging, whether IVUS or OCT was used to guide PCI. So now looking at the different antiplatelets that were used and breaking them down between the 2 groups. So looking here, this is at the 1-month visits after randomization. You can see that the DAPT, so again, the abbreviated DAPT group after 1 month is not going to be primarily on DAPT. They're going to be on single antiplatelet therapy. So you can see here that 54% of these patients in the abbreviated DAPT group were on clopidogrel, which was the most common antiplatelet. 29% were just on aspirin, 13% were on ticagrelor, and only 1% were on prasugrel as their single antiplatelet agent. And the patient with that were on DAPT in the standard treatment group, 79% were on clopidogrel, 18% were on ticagrelor, and 2% were on prasugrel. So clopidogrel was the most common P2Y12 inhibitor used, both for monotherapy and also for DAPT. So now we'll just go through the different outcomes, the primary outcomes. And here you can see the blue is the standard DAPT treatment. The yellow is abbreviated DAPT. And this is looking at the cumulative incidence of net adverse clinical events between the 2 groups. And as you can see, at the end of the study period, the cumulative index was approximately the same. It was 7.7 for the standard DAPT, and it was 7.5 for patients who only had 1 month of DAPT. So abbreviated DAPT was non-inferior to standard DAPT in terms of net adverse clinical events. Looking at the second primary outcome, which was major adverse cardiac or cerebral events, again, you can see that between the 2 groups, there's no significant difference at the end of the study at 1 year. So abbreviated DAPT was non-inferior to standard DAPT in terms of major adverse cardiac or cerebral events. And then the third outcome of bleeding, you can see that there was a significant difference between DAPT, standard DAPT and abbreviated DAPT. So in patients who only had 1 month of DAPT, it was superior in terms of major or clinically relevant non-major bleeding. So just to go through some of the secondary outcomes between the 2 groups. So here's abbreviated DAPT and this is standard DAPT. You can see that there's no significant difference between death and the outcome of death or MI. There is a decrease in the incidence of stroke and bleeding in the abbreviated group, which was significant. There was a decreased risk of stroke and bleeding. So now they looked at, they did a subgroup analysis for each of the primary outcomes to see if these outcomes and these results hold up when you compare different subgroups. So the different subgroups they looked at was patients that were on long-term oral anticoagulation, patients who had an acute MI within 12 months prior to randomization, what their indication for PCI was. So they compared patients who came in with ACS versus stable CAD, looked at DAPT score, looked at precise DAPT score, sex, creatinine clearance, age, diabetes, and also geographical area. And as you can see here, when comparing each of those subgroups, the results do hold up in terms of there's not much significant difference between the two groups when you compare the abbreviated DAPT versus standard DAPT in terms of incidence of net adverse clinical events. So regardless of their indication, regardless of if they're on oral anticoagulation, that relationship still holds up. And then they also looked at for the other primary outcomes, looking at major or non-major bleeding between the different subgroups. So even if they're on oral anticoagulation, you can see that the bleeding clearly favors patients who have an abbreviated DAPT. So in conclusion, the discontinuation of DAPT after 1 month of PCI was non-inferior in terms of net adverse clinical events and major adverse cardiac or cerebral events when compared to standard DAPT therapy. It was superior in terms of major or clinically relevant non-major bleeding when you compare the two. Just some strengths and limitations of the study. So I thought it was a well-run study. This was the first trial, randomized control trial in high-risk bleeding population that was actually powered to demonstrate. Like other randomized control trials that looked at timing of dual antiplatelet therapy, did not exclude patients with ACS. It didn't have restrictions in terms of how complex or the number of lesions that were treated. Some of the limitations, so I think there's some limitations in terms of the generalizability of the study. They specifically focused on patients who are at high risk, so it's unclear if these results can be extended to patients who are not at high risk for bleeding. They specifically used these biodegradable sirolimus eluting stents, so it's unclear if these results can be extended to other stent devices.
Zane, do you think the results would be different in the lower bleeding risk group?
It's unclear. I think some of the things are obvious. So bleeding risk maybe not different, but I think it's hard to say. It's hard to say if you stop DAPT at 1 month following PCI, if patients who are not high risk, if they're going to have more ischemic events. And then there was no mention of imaging. I think that's it's important to at least report if IVUS or OCT was used to guide intervention, especially because we know that underexpanded stents leads to increased stent thrombosis. So I think it would be important to at least mention imaging guided PCI. One other limitation is that the study does exclude patients from randomization if they had any type of ischemic or bleeding events during their first month following PCI. So that can potentially result in some selection bias if you're not including those patients. There was also a lot of variability in terms of which antiplatelet therapy was used, and also the duration and the dosing as well. So I think if there was, if it could be a bit more standardized, I think that would strengthen the study. So just some take-home points of the study. So 1 month of DAPT may preserve ischemic benefits and reduce bleeding risk in patients who are at high risk for bleeding following PCI with drug-eluting stents.
Yeah, Zane, can you go back to the previous slide?
Yes.
So I mean, this is the main slide. So take-home points. Obviously, multi-center randomized trial and one of the best evidence we have, broad inclusion criteria, like you mentioned, very few exclusions. So, that's great that we have this information now. And, I think obviously very important to identify who is a high bleeding risk patient right before we implement this evidence. I think that's, I guess, one of the threats potentially from this is inappropriate implementation and the patients who are not at high bleeding risk. So, but even if you see the event rates, they're only a little bit, at least when I'm reviewing with Twilight and other trials, the bleeding rates are in Twilight is like 4 to 6%, and here it's about 8%. So even in day-to-day practice, we do see a lot of patients who are actually at high bleeding risk. So I think identifying the patients at high bleeding risk and implementing this is key. And about the first month exclusion thing, I guess the implementation is going to happen at the 30 to 45 day time point when one of us is seeing this patient in clinic is sort of when we can assess their bleeding risk and implement the evidence from this trial. Right. I mean, obviously weaknesses are not much, I think, apart from, I guess it's open label, but again, I think they only looked at hard events, right? There's no like angina driven stuff. So I guess that's okay. There's only one stent platform, but contemporary stent platform, right? not much over there. I guess the only thing is, infrequent events like stent thrombosis and stuff. I guess we cannot, dissect out much well because it's a small sample size here. But overall, at the end of the day, we'll be comparing events 1 year or so, and the stent thrombosis events are low anyway. But that's something we cannot really glean from this about stent thrombosis and how that is affected by this. Any other points anybody else has about?
Zane, do you know how many people were excluded because of an event during the first month after their PCI? Did they give you any numbers?
They do mention there's actually quite a bit, I think. It's in the paper, but I think they mentioned that as one of their limitations, that so during the screening period, they actually only end up screening or enrolling 4% of those patients. So it's pretty. There's a lot of patients that they ended up screening out.
Thanks, Karthik. The only thing I would mention is that the way that this trial is conducted, not dictating which P2Y12 inhibitor is used and not dictating what is single antiplatelet therapy, it really argues that the stents are the secret sauce here, that it kind of doesn't matter what you do as long as, and they only 40% got post-implantation further expansion of their stents, very little IVUS use, or they didn't tell us. So my assumption is that it wasn't a lot. So it really doesn't matter how you implant it or what you do afterwards. The stents are really just that good. That would be my takeaway. I think that we do a great job here of careful implantation and following all the rules and doing imaging and optimizing, but even under suboptimal conditions in this trial, it was pretty spectacular results.
Zane, the Ultimaster stent, do you think we could generalize this to the stents that we have in our lab?
Yeah, I don't know. I think that's I think one of the limitations. So I think other stents have to be used as well.
So the Ultimaster is, it's not ultra thin or anything, right? It's just a regular. So I'm just seeing it's 80 micrometers.
It's 80, and then Xience and Onyx are both 81. So I think it's pretty similar in terms of current generation drug eluting stent.
And the coating is also, it's abluminal as well as a gradient to the outside, and then biodegradable polymer. So I guess pretty similar to what we use. I don't know what the strut shape is here, but
I think it's
you know,
most similar to the synergy stent.
mhm. And like you showed in the population in table 1, the high bleeding risk is essentially a lot of it translates to age, right? The mean age you have is 75 years compared to, all these other trials of antiplatelet therapies in which mean age is about 65 years or so. So that's what drives most of, the identification of high bleeding risk, and goes into the precise DAPT score and everything. So, I think it's especially pertinent to elderly population, and also population on anticoagulants. I think both of them.
Any other comments or?
All right, so I think we ended early here. Thanks a lot, Zane. That was an excellent presentation. Obviously, a very pertinent topic. And so until next time, thank you everybody for joining.
Thank you.